I'm one of the red cell CNSs at University College London. So today we're going to talk about chelation and iron overload in thalassemia. Hopefully you can all see my slides. Any questions, you can pop your hand up or pop them in the chat. The view's a bit funny on Teams when you're presenting, so if we miss you, I'll come back to you at the end, so don't worry. But yeah, please put any questions there, and hopefully you find it helpful. Okay, so we're going to talk about iron overload and the treatments that are available to our patients, and hopefully you've heard of some of them. Okay, so iron overload, I'm sure most of you know why it occurs. So it occurs over a period of time when the iron intake is higher than it should be, so higher than your dietary allowance or dietary recommendations. So in thalassemia, we see this primarily due, well, not primarily, but largely due to the red blood transfusions that they have, blood cell transfusions that they have, monthly if you're a thalassemia major, as it used to be called, maybe a bit less frequently if you're a thalassemia intermedia, but this can change and generally increases as they get older. We've moved away now from thalassemia major and intermedia, and they're kind of grouped into transfusion dependent and non-transfusion dependent thalassemia, just to make it a bit easier. But obviously their genetics and phenotypes kind of dictate what they are. To make it easier, they're just in the two camps now. The other way that they load iron in thalassemia is they have increased absorption through the GI tract, and primarily this is in those non-transfusion dependent thalassemias, so the intermediates that don't receive transfusions, but we see a lot of them that they have iron overloaded because they've absorbed it through their GI tract. The other thing that we see, not so often now, but it does still happen, is if an individual has gone to see their GP and they have anemia, and so a GP who doesn't realise the significance of a thalassemia syndrome may say, well, take some iron, it will help improve your haemoglobin. Obviously, this isn't the case. It's not going to correct the anemia because there's a genetic reason for that, but they'll still put them on iron tablets and hope it will help. And quite often they will not stop them because it doesn't improve the anemia, so they'll leave them on the iron tablets. Obviously, this leads to iron overload as well. So it's very rare to give a thalassemia patient iron, and if they do have it, then it obviously should be very short durations. So we need to ensure that the iron overload is managed so we can avoid the toxicities that can be fatal to our patients. And there's quite a few of them that we'll go through a bit later on. So I wonder if anybody knows how much iron is in a unit of blood. If you know, pop it in the chat. No, so it can vary slightly, but it's about 200 milligrams of iron. And this is obviously, so if you've given ferrous sulfate or whatever it's called now on ward or already, that's the equivalent of 1 tablet of iron. And these patients are having 2+ units, 3 to 4 weekly. So it can build up, obviously over their lifetime. It's quite a high proportion of iron that they're taking in through the blood transfusions. It does vary slightly depending on hematocrit. So it will change slightly, but a good rule of thumb is to say 200 milligrams per unit. So this is just a diagram of how much iron a person will load. So a 20 kilogram person, well, I guess that's probably a child, and yearly they're going to load 2.3 to 4.6 grams of iron, daily 6.3 to 12.6 milligrams. So it's quite a significant amount of iron that patients are loading. I always find it quite surprising how much they do load. So the distribution and consequence of transfusion iron overload. In the absence of iron overload, the uptake of iron goes to the cells, and this is done with interaction from the transferrin with its receptors. So transferrin is a protein produced by the liver. It regulates the absorption of iron into the blood. And total iron binding capacity relates to the amount of transferrin in your body that's available to attach to iron. So when iron overload happens, when it occurs, the transferrin becomes saturated. There's too much iron floating around. There's no receptors for them to attach to. So the non-transfusion, non-bound iron is absorbed into the tissue. So it then goes, that's when you start seeing it going to the liver, to the heart, and to the other organs. And you'll see it in the serum as ferritin or hemosiderin, which ferritin, hopefully you've all heard of it. It's the big one that we use to measure iron overload on a frequent basis in our patients. So hopefully you can see this. I don't know if it's a bit small, but it kind of gives you a list of where patients are going to get their iron from. So it's separated into transfusion and non-transfusion dependent thalassaemia patients. Obviously, we've discussed the iron that comes with each unit of blood. And in the non-transfusion patients, it's due to ineffective erythropoiesis and increased intestinal absorption. So let you see, look at that. So how do we measure the iron levels in a person's blood? So it's really important to measure it, which is why patients having regular blood transfusions should be under a specialist centre. Many will have their actual transfusions at a local service, so it's easier for them, but they should all be, as we know, coming to a specialist unit or a unit that's got knowledge of thalassaemia and how to manage the complications. So without the careful monitoring, obviously, it's just so many things can go wrong. And a big one is that we won't be able to adjust the treatment or the chelation effectively and make sure that they stay well. So we can monitor ferritin we can monitor the iron level, in 3 ways. So the first and easiest and cheapest way is the serum ferritin. It's a blood test. It's quite readily done. Hopefully you're doing it on your patients regularly. We do it at UCH with every transfusion because it helps you see a trend, and it's a good marker. The patients quite like it as well. The second one is a liver iron concentration, so a ferroscan or a LIC that looks at the amount of iron within the liver. And the third is a cardiac T2 star, which again is an MRI that will look at the amount of iron in the heart. The ferritin is really good. It will show you a trend, but it does have its downsides in that it will change with any inflammation. So if a patient has a cold or they've been really unwell, their ferritin will jump up, and so it's not a true representation of actually what the ferritin is in the body at that point in time. Hopefully it's just a short peak in a ferritin and it will come back down, so you try not to panic when they get a jump up. You have to look at it over another couple of months' time to make sure that it is a true one. Sometimes it doesn't come down, so patients religiously taking their chelation and it won't come down. Sometimes it takes a little while to shift if they're really heavily iron overloaded. Yeah, so the advantages of monitoring a person's ferritin: it's easy to access and easy to repeat. Every time they have a transfusion, they have a blood test, so there's no reason why you couldn't do it when you're taking their cross match. It's pretty cheap to run, and it does identify possible trends in their ferritin, their iron loading. Patients like it because they can, so on our system we can plot a graph, so they can really see kind of, yes, at this point in February I really started to see taking my chelation properly, and it comes down. So they quite like it from that point of view, and it's good for the dose adjustment of any medications. It's difficult to adjust the dose if you don't have this information readily to hand. because obviously you can't do the scans as often as you would need to. So the disadvantages there, so it's indirect estimate of iron burden. Sometimes you'll see there won't be a correlation between their ferritin and what their liver scan or their heart scan is showing. So you'll be treating them for a ferritin that's in the thousands, and actually when you come to do it on the liver iron, it will be a lot lower. So there can be a discrepancy there. It depends sometimes on the disease, the type of thalassemia they have, but it is something that does happen. As I said before, any inflammation in the body will increase it. Particularly difficult if they have got some liver involvement. You know, they've had a lot of iron in their liver and they are cirrhotic or something like that. Obviously, that's going to really push the ferritin up. So they might not have iron, but it really will look like they have on a ferritin blood test. It's not quite a linear response to the iron loading when you get to really high levels, and its absence doesn't. If it doesn't decrease, it doesn't exclude a response. As I said before, it could just be lagging behind. I think they're the main ones. So I don't know if any of you have seen a ferrous scan report, but this image on the right is kind of what we get. It's an MRI. That yellow bit is the liver. So you can see the more yellow it is, the more iron there is. And this patient had a liver iron concentration of 26, I think that says, or 28 milligrams per gram dried tissue. Normal is up to about 1.8. Obviously, we want our patients to be as close to that 1.8 as possible. It's really difficult to manage, even for the most compliant patient. You know, they're constantly absorbing more iron from transfusions or from their gut absorption, so it's difficult to manage. I think below 5, as a general rule of thumb, in a thalassemia patient is pretty good. So the liver iron concentration, the ferrous scan MRI, it's quite a quick scan. It's 15 minutes, so hopefully most patients can tolerate it. It's widely available, and it is, you know, really widely relied on in the population of our patients. So it helps identify whether the body iron is adequately controlled. Said before, the normal value is up to 1.8, and you'll see an increase in you know, not just in thalassemia patients. So anything with anyone with a liver iron concentration of above 15 to 20 milligrams per gram are likely to have a worse prognosis, so fibrosis and cirrhosis, or liver function abnormalities. So it's important to obviously to get that down. To determine the iron balance, the scan allows us to see whether it's a decreasing on the current therapy or increasing, so it's a good way to monitor. We tend to do them every year here at UCH, but if we know a person has got a really high liver iron concentration, we will repeat them more often, maybe 6 monthly. You know, it's good for us as clinicians to be able to see that the results are going down, but it's also good for the patients that are, you know, being really compliant with their therapy. They're not seeing a change in their ferritin. It can really spur them on to see that it's actually doing some good. So advantages: it's the most reliable estimation of body iron. It allows you to calculate the iron balance within the body and the change in the liver iron. If you can control your liver iron, the prognosis is better, rather than just relying on ferritin. It doesn't change with inflammation within the body like a ferritin would. It's non-invasive, but it is an MRI, so there's some people that just can't do it. It's easy to set up in theory because it just happens on a normal MRI machine, a slightly lower weighted MRI machine. But it's quite easy. You just have to, I say you just have to, it's, you know, obviously a big trust thing to do, but you have to pay an external company to review the scan. So the picture that I showed you before of the ferroscan doesn't get done on a normal reporting system. It gets sent to another company. They report it and send it back to the hospital that did it. It is expensive, obviously a disadvantage there. You can't repeat it as frequently because of the cost and because, you know, the length of time and getting people there. You can't use the ferroscan, the liver iron concentration, to kind of assess the heart iron. So there's not a direct correlation with, you know, if you've got an extremely high liver iron, you don't necessarily have any heart iron, or, you know, your mild liver iron and you could have a really high heart iron. So there's not a correlation directly between the two, so you can't rely on that. Biopsies, they come with their own risks, lots of complications with things like that. MRI it's not readily available, and as I said, it requires external validation. So there are a few things that would hinder you. It would also stop counting at a certain point. So we get results of up to 43 milligrams per gram dry weight, and then it will just say above this. It doesn't, you know, so it could be 44, but it could be 80. So there is quite a large discrepancy in patients that are really iron overloaded. Cardiac T2 star, again, it's an MRI done in the same, quite a lot at the same time as a ferroscan would be done. It takes longer, so that's a big issue if people are claustrophobic and not able to tolerate the scan. It does take a bit longer. It takes up to an hour to have the 2 scans. So it enables us to look at the amount of iron that is stored within the heart, and it shows the risk of likelihood to go on to develop heart failure if you've got a T2 star with that's under 10 milliseconds. Excuse me. It's quite a high correlation as if you've got a poor T2 star, which is the measurement of the heart iron, that you will go on to develop you will go on to develop heart failure. So advantages, it's readily assessed in relation to heart iron. It's, you know, it's widely accepted. It's reproducible. You can do the same scan again. It directly looks at the heart iron rather than kind of the heart function. So it does look at both of them. So it could give you that correlation. But it's the gold standard in kind of heart iron. You get a different oh, sorry, my computer's, there we go. There is a different way to measure a heart iron on the liver iron scan as well, but it's not as good as a T2 star. So it requires, the same as with the ferroscan, it's expensive. It requires a specialist centre to do it. It's technically quite a challenging scan to do. And it won't kind of give you the total body iron that you want to know within the result of that. So just moving on to some treatments now. Hopefully you've seen some of these. We've got 3 treatments available. Desferrioxamine, which used to be called Desferal, the Thalassaemia, which used to be known as Exjade until quite recently the tablets went generic, and deferriprone, which when it first came out was known as L1. So there's 2 oral ones, the Thalassaemia and the deferriprone, and the desferrioxamine is an infusion that patients administer at home. So desferrioxamine was the first one introduced in the 60s. The current guidance is not to start it until a ferritin reaches about 1,000, or they've had 20 units of blood, 20 transfusion episodes. It can be given subcutaneously or intravenously. At home, most patients will give it subcutaneously. They only give it IV if they've got an indwelling port, so a portacath or a PICC line. And it will go over 8 to 12 hours, 3 to 5 to 7 times a week. About 3 to 4 is the standard. It's good because you can dose adjust it. So normally, well, the range can go from 20 to 60 milligrams per kilogram per day. It can run over anywhere between 8 and 24 hours, and can be on however many days a week as you see fit, and as indicated by the individual patient and by how compliant they're going to be with it. It's really good for liver and cardiac iron. And the dose can be quite widely, it can be a gram, it can be 4 grams. So it's quite, widely able to be changed for each patient. So some of the toxicities that we see with desferrol, deafness and visual disturbances, they're not common in patients that are really heavily iron overloaded. As long as you adjust the dose as their iron burden comes down, you shouldn't see these. Back in the 60s, when they first developed the drug, obviously they didn't realise this, so they put everybody on really high doses, and subsequently quite a lot of the patients that had it in those early days have now got hearing impairment and visual disturbances. So we're a lot more careful. We to make sure people have eye and ear checks before they start, and every year or so. Yersinia and Klebsiella infections are quite common. They're quite common with iron overload anyway. You're more susceptible to infections, nasty infections that take a long time to clear if you have got extra iron on board. Local inflammation. So if I go back, you can see just the pump on the left, the little bag there. It connects up to a butterfly needle, and then that needle is inserted into the subcutaneous tissue, generally the stomach, but patients prefer, but they can go onto the legs, to the arms, wherever there's some tissue there that can handle it. That can often and does often result in some localized inflammation. So it can be sore, you get red patches, little hard lumps. It should disperse over time, but obviously if you're doing it 5 days a week, you then have to deal with trying to find a new spot to put your needle in at, every day, every dose that you're doing. We can add a steroid into it, a low dose steroid, so that sometimes does help the localized irritation, and it doesn't affect kind of other medications and things like that, because it just is to treat that local reaction. We have some pump issues. They're not made on site with us, they're made at another hospital, but sometimes they run over their time, sometimes they run under, sometimes there's medication left within the pump. So there's quite a few issues that do crop up with it. The Thalassaemia Society is working with the company to see if they can rectify what the issues are. So somebody's asked if there's anything else you can do to help with the skin side effects. Not really, no. Other than rotating the site, adding in a steroid, it's just a bit of perseverance for each individual. It's quite difficult sometimes to manage, but I think most patients do kind of get through it and realise sometimes it's how they're doing it, sometimes it's the placement of the actual needle. If someone puts it in their stomach and they put it in between I say a roll of fat, it sounds horrible, but the needle's kind of sitting in an awkward place, that can cause the discomfort as well. So, but no, other than that, there's nothing really you can do. You can calculate the toxicity score of it. I'll let you all do that if you want to, but it helps you figure out where your patient's maximum dose should be. Deferoxyrox, is often referred to as Exjade. It still is. It only went generic in the last few months because the branding ran it well. We were able to produce it much cheaper now. So it's a once daily oral monotherapy, which is obviously much more preferred by most of the patients. If you can take a tablet or 2 or 3 tablets once a day rather than have a needle attached to you for hours on end, I know which I'd prefer. The dose goes anywhere between 14 and 28 milligrams per kilogram per day in a film-coated tablet. And you can obviously dose adjust that according to their ferritin or their liver iron and their toxicities. Unfortunately, there are quite a few toxicities that you can get with deferocyrox. GI upset is quite common, less so now with this formulation. It used to be an effervescent tablet and everybody got diarrhea or nausea, vomiting with it. So the compliance was really poor. They developed this enteric coated version of the drug, and it's a lot better tolerated with a lot less side effects. Unfortunately, renal toxicity is pretty common. We have to monitor it very carefully, and if they're known to have a renal impairment before, it's difficult to get them onto a good dose. The jury's kind of split whether you need to check eyes and ears for these patients that are taking Xjade, but it doesn't hurt to do it kind of as a baseline, so you have that information to hand. A rash is quite common when you start Xjade or when a patient starts Xjade. So at that point, we advise to stop the Xjade. Oh, sorry, I'm gone back to Xjade. The deferocyrox, we advise to stop it. And then the rash will resolve. It always goes away. And we would re-challenge them on a lower dose of the drug. And then at that point, it generally doesn't come back. And then once they've established on a lower dose, you can increase it as tolerated by the other monitoring aspects of it. So obviously there's some long-term safety data, you know, floating around out there, but it's still quite a new one. And combination regimes are approved now. So deferocyrox and deferol can be used, but you do need to get funding permission for that. The liver and the renal toxicities will often resolve when the treatment is stopped, and then you can often re-challenge a patient and bring them up to a good dose. We tend to go in not too high doses, because once you go in on a high dose, if they do get a toxicity, it's definitely harder to re-challenge them and get them on a stable dose. So we kind of go in on a good low dose, but a lower dose, and increment it as rapidly as we can with the monitoring. And deferoprone, Feriprox or L1, it's another oral chelator. This one you take 3 times a day, so you do get some compliance issues and missed doses. It was trialled in the 80s. It's not very good for liver iron, but it is good for cardiac iron and maintenance. It's intense monitoring. It's supposed to be weekly blood tests. Especially when you start it, but I can say that none of our patients do that unless they've had some issues with it, and then we might be able to persuade them to for a little while. Neutropenia is quite common with deferoprone, so that's why they're supposed to have the weekly blood tests. But obviously they're coming in so often for their transfusions. 3 to 4 weeks is generally where they sit once they're on an established dose. Nausea and vomiting, increased appetite and some stomach pain. We don't have a huge number of patients that are on deferoprone or just on deferoprone. They're generally on a dual therapy, but it is still widely used. And finally, we did some case studies last week, I think, and they're available to watch on our website. And they'll just go through some case studies, some complex ones. There's a pregnant lady and a paediatric case study. So they're really interesting to hear about the issues they face and what was done. Any questions? No. Okay then. Thank you for joining.
Thanks, Bernadette.
Thank you. Oh, compliance. You want somebody's putting in? Sorry, it's just.
Sorry, I can turn on my microphone. Sorry, I missed some of your talk. I'm really sorry, but I'll listen to it again later. Compliance and iron chelation, and yes, you know, it's all about getting buy-in and building relation, all this stuff. But Have you got any tips? Because, you know, and they say they take it and then they don't, because you look at how many they've asked for and they haven't asked enough. And
I wish I had a magic wand and could say, do this, but no, it's like with any chronic illness, they're not going to take it. But we find when you plot it out, I don't know what IT system you have or available to you, but we do, you know, you can plot out on ours, you can plot out their ferritin. So you can say, look, this is where you started taking it because it's come back down. You're telling me now that you're still taking it because we can see it slowly creeping back up. And then once they get that visual kind of check in, they think, oh, okay, somebody does know what's going on. They know I'm not taking it. That does help with some patients. We also try and encourage them to associate it with something that they do every day. Obviously, it's difficult if it's the infusions, but if it's the ferrosirox and it's just once a day, associate that with something you do every day. So every day, do you brush your teeth? Yes. Okay, we'll have your tablets by your toothbrush. So you do the both of them together. You associate it. And just, I mean, you do this. I know you do without even asking, but discussing what the issues are and how you can help, but they're not going to take it if they don't want to, but which isn't helpful. But it's just about working with that individual. If we have really serious compliance issues, we do refer them to the psychologist or the counselling team and see if they can work with them to work on what the bigger issues are and why they don't want to take it.
That's really helpful. Thank you.
Okay.
Are there any patient stories or anything of, you know, because the trouble is, you know, talk about networks, but ultimately when you live in an area where you don't have lots and lots, then often people are related to each other. So actually they don't want to be, you know, it's, are there any patient stories?
Trying to think. If you watch the case studies are more kind of complex cases of people that they struggle to find the right chelation for. But yeah, I mean, I'm happy to kind of have a think, Jane, and if you want to drop me an email, we can maybe catch up about some particular patients and what they did differently and things. Off the top of my head, I'm struggling to think of somebody.
That's cool.
But
It's just nice to have a friendly face, isn't it? That you can
yeah,
phone up and have a chat. And also, you know, people do resources, don't they? And often it's good to share rather than invent the wheel again.
exactly. It definitely is. Which trust are you at?
UH&M, so up in Stoke.
Okay, fine. We've got patients that are always happy to talk to other patients. If you think that would be helpful, we can give them your detail, put you in contact with them, and it just depends if the patient in question is kind of somebody that would respond well to that. But we have got patients that have gone, you know, above and beyond and really pulled themselves back and done so well. Okay, any more questions? Okay, that's great. Thank you for joining.
Thank you ever so much.
Okay.
Thanks. Bye.
Bye.